Hello, I'm your host, Dr. Braha. Welcome to the Zermed Show. On the show, we will feature local community physicians who are experts in their respective fields and who will share their experiences and wisdom with us. We cover a broad range of health topics on the show, and today we will discuss venous thromboembolism. I know it's a complex term, but we have Dr. Hal Chadow with us, who is the Director of Cardiology and Cardiac Catheterization at One Brooklyn Health, and he will explain this to us today. Welcome to the show.
Thank you so much for having me.
It's nice to have you. This is a big topic. It's a very important topic, and I'm sure our viewers will realize that as we get through the message we have about venous thromboembolism today, where blood clots from the legs sometimes travel up to the heart and can cause some major medical problems, including death. And we want to talk about that and educate our viewers. But first, everyone wants to know a little bit more about you, and tell us where you're from and how did you get to where you are today as the chairman of cardiology.
So thank you so much for having me on your show. I was born and raised in New York, and in fact my family is from Brooklyn, so I feel in a way that I'm coming back to my roots over here. I went to Brandeis University for undergraduate. After graduating with a BA in biochemistry, I went on to medical school in Guadalajara, Mexico, and completed my medical school training at New York Medical College in Valhalla. I was then fortunate to get accepted to an internal medicine residency program at Long Island Jewish in Long Island. And after that, I went to SUNY Downstate for my cardiology fellowship. It was around this time that the training for interventional cardiologists, which is a cardiologist with training specifically in the management of cardiac catheterization, inserting catheters to the heart, so we can take a look at the arteries, we can take a look at how the heart is pumping, we can measure the pressures in the heart and the lung, was becoming standardized. And I was the first interventional cardiology fellow at SUNY Downstate. I also spent part of that year at Maimonides Medical Center, so I was really exposed to the latest and the greatest in the world of interventional cardiology. After that, I was asked to come back and join the full-time faculty here at Brookdale University Hospital and Medical Center and SUNY Downstate, where I'm also a professor of clinical medicine. So in addition to my clinical responsibilities, I also teach medical students, I teach residents, cardiology fellows, and interventional cardiology fellows. It's been a dream job because I get to do everything that I love. I get to treat patients. I get to do procedures that are life-saving, and I get to teach the next generation. So really, it's been beyond rewarding. In 2000, I was made the chief of cardiology, and during that time, we actually expanded cardiology services here at Brookdale Hospital, and more recently at One Brooklyn Health. And so the interventional part of the story began in the late 1990s. Up until that point, we had really been treating heart attacks with clot-busting medicines. They could be delivered quickly, but the problem was they only worked 2/3 of the time. And the other big problem was that they caused bleeding, sometimes fatal bleeding. And so there was a search to look for a better way of managing these patients coming in with massive heart attacks. And that search led to the development of a procedure called primary angioplasty, where we're able to thread a thin wire and a balloon across the blockage and restore flow almost immediately. And actually, that procedure was successful in over 95% of patients, lowered mortality, and you now basically change the landscape. The problem was that only about 18% of hospitals in the United States have on-site cardiothoracic surgical program, which at the time was really necessary. So the next advance was to answer the question, can we perform these procedures at hospitals that don't have on-site cardiothoracic surgery and do them safely without adversely affecting the patient? And the answer was obviously yes. And New York State, therefore, opened up the ability for hospitals to apply for that program. We were actually one of the first programs to be approved, and we started that program in 2007. A few short years later, the state realized, hey, if they can do this successfully, maybe they can also do elective procedures equally as well, and more importantly, equally as safe. And so we then began to develop an elective angioplasty program. So we're now able to treat a whole host of cardiac conditions right here in the heart of Brooklyn in East New York. We talked about venous thromboembolism. So yes, it's a big word. And venous thromboembolism encompasses clots that develop in the legs. And the word for a clot is obviously a thrombus. When a piece of that clot breaks off and travels, we call that an embolism. And so the problem is that what puts you at risk for the VTE? A lot of times it's immobility. It's immobility because of a leg injury. It's immobility because of leg surgery, whether you had a knee replacement or a fracture fixed. It's immobility because of surgery and you've had a long hospital stay and you haven't been getting out of bed, or you're morbidly obese and you're not moving as much as you should, or you're born with a clotting disorder that actually puts you at increased risk to develop clots. So any of these conditions can actually lead to a venous thromboembolism, or for short, VTE. When that clot breaks off, the concern is that it'll travel to the lungs. It'll travel through the heart and go to the lungs. And the problem there is once that clot is big enough, it will obstruct the flow to the lungs. The lungs are our source of oxygen. That's where the gas exchange happens. Without our lungs, we can't breathe, we can't live. And so if the clot is big enough, about 1 in 3 of those patients may die. And even if it's not so big as to obstruct a lot of the flow, even the smaller clots still have a mortality of about 10 to 15%. So we're talking about a huge problem. How many patients are we talking about? It's estimated, although there are no exact numbers, that for venous thromboembolism, it's probably about 120 for every 100,000 patients. For PE, for pulmonary embolism, when that clot goes to the lung, it's probably 60 per 100,000 patients. But the morbidity, the chronic disease that can occur, the right heart failure from untreated, uncorrected disease is significant. And the mortality is significant. So as we said before, this necessity is the mother of all invention. Things happen in life because of an experience that happened, and you want to do it better. So around 4 or 5 years ago, we had a patient who presented with a clot to their lung, a very young patient. And we used the traditional clot-busting medicine. And unfortunately, that patient didn't make it through. And we said, there has to be more that we can potentially do to save these patients. And that research led us to develop what's called a PERT team, a pulmonary embolism response team. This is a group of physicians which encompass interventional cardiologists such as myself, general cardiologists, vascular surgeons, cardiothoracic surgeons, and critical care physicians who all work together to develop protocols so that we are able to systematically manage any patient that comes into any one of our facilities with a VTE. So whenever a VTE is diagnosed, we get a phone call and we jump into action. We're able to evaluate that patient and then decide based on the patient's clinical presentation what is the best treatment for that patient.
So the patients who come in to the emergency room with signs and symptoms, and they see that there's a pulmonary embolism, all of a sudden this team of experts is activated.
Correct, and it's 24/7.
24 hours a day.
24 hours a day.
And these doctors can then dictate what the best treatment would be for a patient who has this blood clot that unfortunately has traveled up to their heart.
So the beauty of an electronic medical world, an electronic medical record, is that we can actually see everything that the ER sees, or almost everything that the ER sees, in real time. So by time we get the phone call, we can see all the labs. We can see that CAT scan that was done showing exactly where the clot is, how extensive that clot is, how big the right side of the heart is doing, and any other diseases that that patient has that may influence what we might do.
So even before the patient has even seen your face, you know what's going on because of the technology we have today, where you can pull up images and labs from even your phone sometimes.
Correct.
So now, if we have a patient who comes into the ER and they've been defined to have a venous thromboembolism, so what are the treatment options? Because you told us about all the wonderful treatment options that we have for heart attacks and how it evolved over the years to go from medications which worked well but not so well to catheterization, where we can take a little wire through sometimes the wrist or the groin, a little hole, to get to someone's heart and save their life. What are the advances now for the treatment of VTE for these blood clots that travel to the heart?
Excellent question. So when we talk about VTE, we talk about three different categories. Massive pulmonary embolism are those where the patient is an extremist. The patient is coming in extremely symptomatic. Their blood pressure is low. They are requiring medicines to maintain their blood pressure, or they may have had a cardiac arrest.
Meaning their heart stopped.
Meaning their heart
CPR
stopped,
was started.
CPR was started, and they were revived. In those patients, typically we will give clot-busting medicines. But some patients actually have what we call contraindications, meaning medical reasons why they can't receive that drug. Maybe they have had brain surgery in the past. Maybe they have cancer with metastatic disease where the disease has spread to their brain. Or maybe they had a recent surgical procedure and they can't get that clot-busting medicine. So in that situation, we will emergently bring them to the cath lab within a very short period of time.
And this is the lab where we treat heart attacks with
Correct.
with the catheters you were telling us about in the beginning. So the same place you're treating heart attacks now, you're going to bring this patient with the blood clot in the heart.
That is correct.
That's blocking the other side where the blood flow to the lungs goes.
So it is not uncommon in our day that in the morning we could be treating a heart attack, and in the afternoon we could be treating a VTE patient in the same place, in the same lab.
Tell us how this works now for the thromboembolism, the blood clot that went to the heart. Tell us how you treat this now in the cath lab.
So what we'll do is we'll put a small catheter into the vein in the groin area called the femoral vein, and we will advance catheters. We will measure the pressures in the heart and the lung, and we'll do what's called a pulmonary angiogram, which means a picture of the lung with dye, to see where the blockage is, how extensive it is, and how we're going to treat that. If we identify that clot can be treated, we will then put in much larger catheters, and we do what's called a mechanical thrombectomy. So thrombectomy is another big word, but again, it's thromb meaning clot, ectomy meaning taking it out. So we're actually able to physically remove these clots from the lung. And again, it's almost instantaneous that the patients begin to feel better.
As you pull this clot out.
As you pull this clot out, you know, we've had patients who are on respirators, who are on 2 medications to elevate their blood pressure, and within hours, their requirements for the blood medications to keep what we call pressors, to keep their blood pressure up is gone, and they were able to be extubated. They're able to be taken off the breathing machine within 24 hours.
So how do you get this? Is there something you grab it with? Do you suck it out?
So there are a couple of different technologies. One involves a mechanical, where the machine is creating the suction and you're pulling it out.
You vacuum out the clot.
You're vacuuming out the clot. The device that we have been using more recently is actually a much larger device called an Inari device, where we actually basically suction, create a negative vacuum so that you're actually able to suck the clot out from the lungs And you're able to see within seconds
Amazing.
how blood flow is restored, and these patients begin to feel better. They're like, wow, doctor, that weight on my chest is gone. I could breathe. And if their oxygen level had decreased, you could actually see almost immediately how their oxygen levels are now restored to normal.
So patients who come in with these signs and symptoms who are found to have a blood clot, 24 hours a day have the availability of this team, the PERT team, to come in and address this, just like you've been doing for heart attacks for a number of years.
Correct.
So now you're treating the heart blood vessels, now you're treating the vessels that go to the lung that may be blocked. After the treatment, what happens to the patient? How do we prevent this from happening again? What are the steps that you take to help these patients from ending up with another blood clot of the lungs or the heart?
So I just add, before we go to there, I just want to add one more thing. We actually have 4 different labs. Any of these labs are able to treat any of these patients, but the third group of patients that we've been treating for the past few years is strokes as well. So if a patient comes in the throes of a stroke, especially within the first few hours, 6 hours, we're actually able to take that patient to the lab as well.
Because the stroke is also caused by
a clot.
By a blood clot.
Right. Not our team, but there's a separate, highly specialized team of neurointerventional radiologists who are activated on call 24/7 and are able to manage those patients as well.
With the same types of catheters and the process of going into the brain for a blood clot, just like you were doing for the heart, doing for the lung, and now
Correct.
a team for the brain.
Right. So getting back to your last question, sorry for that little detour
It's
over
important
there.
for the viewers to know how medical science has advanced so incredibly in treating diseases that are caused by blood clots.
Correct.
Blood flow is important for the brain to survive, the lungs to survive, the heart to survive, and this has been a major killer of people, or a major cause of morbidity, like you said, meaning that the person is ill for the rest of their life, sometimes paralyzed, or they can't walk, or they have trouble. So preventing death and preventing illness by removing clots, mechanically, with your hands, instantly, it's incredible. So tell us about how we prevent it from happening again. What is the patient, after they leave your hands, and back to their primary care doctor or to their regular cardiologist, what happens?
So I would say, firstly, we do send them back to their primary care always. But if they don't have a cardiologist, then we will follow them as well. Because we feel that we want to make sure, A, that they're taking their medication appropriately, and B, that we can prevent this from happening again. So how do we do that? So we divide these patients broadly into 2 categories, provoked and unprovoked. And as the name implies, provoked means, did something happen to the patient that was acute and reversible that caused their clot?
In the first place.
In the first place.
What was going on right before they showed up with this blood clot to the lung that might have started it? You're the investigator.
Correct. So the question is, did they have a leg fracture? Did they have surgery? Did they have some kind of prolonged immobility that is no longer there anymore? We call that provoked. If that's the case, then we'll put them on blood thinners for about 3 months, and assuming that there's no underlying cancer, there's no underlying congenital problem that will put them at risk for developing clots, then we will put them on blood thinners for about 3 months. Then we'll stop it, and then they should be fine. The recurrence rate for those patients is going to be very low. Obviously, if those patients have a second event, then they are committed to almost lifelong blood thinners to prevent this from happening.
Right.
If it's unprovoked, meaning they don't have any predisposition to develop clots, or they're a cancer patient, or you just don't know why it happened.
Genetically sometimes, right? Sometimes they have a genetic problem where they produce clots.
Correct. But even if we can't identify that genetic problem despite our extensive testing, which we do on almost every patient that comes in with a VTE, then for those patients, they are going to be on what we call long-term anticoagulation, or they are going to receive blood thinners that they'll take once or twice a day, pretty much for the rest of their lives. And that will prevent the clot from recurring.
So we're talking about, for our viewers, and this is a disease that's serious, because sometimes we hear stories about some famous people who were on an airplane or They were laid up in bed due to an injury after a football injury, and for months they're in bed with a leg that's not moving. And they suffer this deadly disease called a venous thromboembolism, which you can now save their lives with your hands by retrieving a clot or giving clot-busting drugs. You can prevent it from happening again by using blood thinners. I guess for the viewers today is they want to know how to stay out of this problem in the first place. How do we prevent blood clots in the legs, and specifically, how do we prevent them from going up to the chest? What are some of the symptoms they can detect early before that actually happens?
So before I answer that question, which is excellent, I would say that we could only treat patients if they seek medical attention, right? So they really have to be paying attention to what their body is telling them, and all of these symptoms that we'll now talk about, but they have to actually come,
They have
right?
to know what's going on is wrong and seek medical care.
Even if they are not 100% sure that there is what's wrong, what exactly is wrong, they have to realize that something's wrong, and I got to seek medical care.
What are some of those signs and symptoms?
So the signs and symptoms that they should be looking for are swelling of the legs. And sometimes that swelling may be unequal, or especially if it's unequal. And sometimes patients will come to the office. I'm sure you hear the same thing. You know, doc, yeah, my legs swell, but I put them up at night and they go down. That's not what we're talking about. This type of swelling doesn't go down at night. This is the type of swelling that continues and is irrelevant what they're doing. Elevating the legs does not relieve that swelling.
And it's often one side as opposed
to
to
both.
not always both sides.
Correct. It's one side. It may be bilateral, maybe both sides, but more commonly it's one side. The swelling doesn't go down, and in fact it may actually increase as the clot extends itself. And it becomes more painful, more swollen. They should be seeking medical attention. For signs of pulmonary embolism, the most common signs are chest pain, shortness of breath, feeling anxiousness, difficulty breathing, difficulty finding a place for yourself, because what's really happening in that instance is the lungs are not able to give you oxygen because the blood flow is compromised. And so those are signals. And I would beg your viewers, it's better to come and get evaluated and find out that it was nothing than not to come and say, just indigestion. And
the better safe than sorry adage.
Better safe than sorry.
If you notice that you have leg pain, especially if it's on one side, especially if there's swelling, redness, tenderness, go get checked out immediately.
Correct.
You'd prefer not to meet these patients and prevent it in the first place before it travels.
That's
to the
correct.
lung, because that's when there's extremis, that's when there's an emergency. So those are some very, very important signs and symptoms. In our last 2 minutes or 3 minutes here today, what do we do to prevent that from even starting? How do we prevent patients from getting into the position where they develop blood clots of their legs or of their lungs?
So the most important thing that any patient can do, and this is for almost any cardiovascular disease, is mobility. Move, move, and move. I tell my patients, and this was based on a study from Harvard many years ago, you can actually prevent a lot of cardiovascular disease by just exercising 30 minutes a day. And when I tell them that, I say, look, I'm not looking for you to be Jane Fonda. I'm not looking for you to go to a gym and start running on a treadmill for 30 minutes. If you just walk at your regular pace, 30 minutes a day for about 5 days a week, you are going to do so much good for your body. You're going to prevent clots in the legs. You're going to improve your blood pressure. You're going to improve your cardiovascular health. You're going to do so much good for your body that it's immeasurable. Of course, a healthy diet is important to keep you mobile. Diet, exercise, weight loss.
Smoking is an issue with this.
Smoking is a huge issue because it leads to an increase in cancer, which is a big problem. Many cancer patients will develop clots, and therefore for some cancers it's almost routine that even in the absence of clots they will be put on blood thinners. But that is a decision that patient needs to make with their individual physician.
So mobility, exercise, smoking. Jane Fonda. Some of the viewers may not know, we're dating ourselves, but an exercise celebrity. Yes, doing exercise is the most important thing we can do for our hearts and prevention of clots. Patients often ask in our last minute about traveling. And they get on airplanes and they sit for 18 hours on a plane, or they're driving cross-country, or truckers. Do you see an increased risk in those populations, or is that just something we read about or on the internet?
So I would say that the New York to Florida flight is probably not a problem for anybody. For those long-haul flights, across the Atlantic, across the Pacific, those can be a problem. And what I personally do if I travel on those long flights is I get up. I make sure that I get up several times during the flight and that I walk around.
All about mobility.
All about mobility. Even on a plane, you can still, while everybody's sleeping, find a few minutes to walk up and down. And I make sure that a couple of hours don't go by, that I don't make a trip up and down the aisle just to flex my muscles. Because think about what happens, right? On the artery side, the pressure is so high that the heart is generating that flow. On the venous side, the pressure is very low. So what's generating the blood flow back to the heart is mobility. Why?
Yeah.
Because every time you move, your muscles contract. And every time your muscles contract, it's pushing that blood up back to the heart where it needs to be.
Squeezing it up.
Squeezing it up. So mobility, mobility, mobility.
So I think that we learned very easily about how to prevent this from Dr. Chadow, is that you have to move. A body in motion will stay in motion. But God forbid you develop any signs or symptoms of a blood clot with a swollen leg or a painful leg, especially on one side. You need to get it checked out. And someone like Dr. Chadow is probably going to save your life. I want to thank you for watching the show. Venous thromboembolism is common. It is preventable. And now, as we learned today, how treatable it is to stop this from taking somebody's life. So I appreciate your interest in the show, your desire to become more involved and educated. I invite you to visit the website at www.zurmed.com. You can check us out on social media, use our tools, and if you need to reach out, 718-510-2103. Thank you so much for being with us. I really appreciate it.
Thank you so much for having me.
It's been wonderful. Thank you.